ARHP's Communication and Education Associate with a link to the post-test survey. Your continuing education certificate will be generated upon completion of the survey. In 4 weeks, you will receive another email with a link to a follow-up evaluation. We ask that you complete this evaluation to let us know how you have incorporated what you have learned during this webinar into your work. Completing the pre- and post-test, as well as this follow-up evaluation, helps ARHP ensure that we continue to meet your educational needs and interests. Thank you in advance for your time and feedback. At this time, I would like to introduce Dr. Colin Batur and Dr. Ann Calhoun, today's presenters. Dr. Batur did both her internal medicine residency and women's health fellowship at the Cleveland Clinic, where she has been practicing since 1998. She is the education director for the Primary Care Women's Health Program. She sees patients both as a primary care provider and as a women's health specialist addressing hormonal, cardiovascular, contraceptive, and bone health concerns. Dr. Calhoun is partner and founder of the Carolina Headache Institute in Durham, North Carolina, and is professor of psychiatry and of anesthesiology at the University of North Carolina and former senior faculty in neurology. She holds subspecialty certification in headache medicine through the United Council for Neurologic Subspecialties and is a fellow of the American Headache Society. Drs. Batur and Calhoun's full bios are available on ARHP's migraine webinar web pages. We are thrilled to have them with us today, and I will hand it over to them. Dr. Batur, you have the floor.
Thank you very much. Well, first of all, we'd like to thank Amgen for their educational grant to ARHP so that we can have these webinars. Although we're not discussing any Amgen products, we do appreciate the opportunity to highlight the importance of migraine in women. In terms of disclosures, my life is pretty simple. I don't have to have anything to disclose, but Dr. Calhoun is a thought leader in the migraine world, and as such, she has some disclosure with respect to her research support and consultant duties, as well as speaking engagements with a variety of with companies. But none that really apply to the discussion we're having today. What does apply, keep in mind that we are going to discuss off-label uses of combined hormonal contraceptives because none of them have been ever approved to prevent or treat migraine, and none, or estrogen products in general, have not been approved for this purpose. Also, for clarity, sometimes we may use brand names when discussing combined hormonal contraceptives. This is because even though a lot of formulations may share the same ingredients of the estrogen and progestin, they're vastly different in terms of the architecture, how they're put together, and the dosing of the pill, and this can make a big difference in how they impact migraine. We do have actually no conflicts of interest related to any contraceptive. So we're hoping that by the end of this presentation, you'll be able to diagnose migraines more effectively, describe their epidemiology, how common they are. You'll also have a better understanding of the biologic and lifestyle factors that influence migraines in women throughout their lifetime. And then also treat menstrual migraines and also migraines in women who are pregnant, lactating, and those whose migraines worsen with menopause. So jumping right in, a little bit of neurology for the non-neurologist. Identifying migraine. So if you look at the incidence of migraine, it's actually relatively low when you just look at a general population. It's about 13% that are migraineurs. But the numbers in women age 25 to 40 is considerably higher, usually estimated at around 25%. However, in a population of those who seek general medical care, the patients in your waiting room, they're more likely to have symptoms of migraine. Right around 29% of those patients are migraineurs. In fact, if you look at patients who are complaining of headache coming to the primary care doctor office, more than 90% of those patients coming in with recurrent episodic headaches have symptoms that warrant a diagnosis of migraine. So let's talk about diagnosis. This is an international classification of headache disorders criteria for migraine. So this is from the International Headache Society. And essentially you can diagnose a migraine in any patient who has an episodic recurrent headache lasting 4 to 72 hours if they fit any of these two pain qualities here in the first bullet, or any one associated symptom in the second bullet here. So the two pain qualities It should be moderate to severe in intensity, pulsatile, unilateral, and exacerbated by activity. But just keep in mind that instead of being pulsatile, about half of patients can have a steady headache pain, and then about 41% of patients can have bilateral pain. In terms of associated symptoms, we're looking for nausea, vomiting, or light or sound sensitivity, but only less than 30% of patients actually have vomiting. On the picture on the right, you can see here the variety of different locations where migraine symptoms can be felt, and we're going to discuss that a little bit in a little bit. Let's talk about migraine diagnosis. Like we mentioned before, over 90% of patients who complain of headache, chronic headache, actually fit the criteria for migraine. Let's take a look at these patients, these migraineurs. What are they truly diagnosed with? So 48% of them are actually correctly diagnosed. Let's take a look at the others that are not correctly diagnosed. So 46% of those patients think that they have a sinus headache, and 32% of those think that they have a tension headache. Why? Well, let's talk a little bit about pathophysiology. So the once popular vascular theory of migraine, which suggested that migraine headache was caused simply by the dilation of blood vessels and auras by constriction, is no longer considered valid. And migraine is likely caused by a phenomenon known as cortical spreading depression, which is a wave of neuronal and glial depolarization that spreads across the cortex. So this likely activates the trigeminal nerve afferents, which you see here, which in turn causes inflammatory changes in the meninges. So this slide explains the distribution of pain in migraine. So it's carried via these trigeminal nerves, and it's usually the ophthalmic branch that you're seeing up top here. Okay. However, you can have referred pain in the maxillary or mandibular branches as well. So good analogy would be like angina. Typically, you're going to look for that as chest discomfort, but you can also have that being as shoulder pain or scapular pain as well. So if we think of sinus, why people might get a diagnosis of a sinus headache, well, patients can sometimes have autonomic symptoms from the trigeminal nerve stimulation, so the lacrimation, the rhinorrhea, the nasal congestion. And then what about for diagnosing as tension headache? Well, up to 75% of migraine patients experience neck pain associated with their migraine attack. So this is a prospective observational study of 113 migraineurs who recorded the details of their migraine attack, including the presence of nausea, intensity of headache, and whether they were having neck pain. So if you take a look at the results, it's quite interesting. So regardless of the stage treated or how severe their migraine was, the migraine is more likely to be accompanied by neck pain than it is by nausea. So in general, if a patient has if you see in the patient's chart diagnosis of sinus headache or tension headache, think twice and think that they might have a migraine headache until proven otherwise, and spend a little extra time with their history. So jumping into the life cycle, throughout the woman's life cycle, let's start with children and adolescents. Headaches are common in children and adolescents. In fact, it's the most common pain complaint among children and adolescents seeking medical advice, with migraine and tension type headaches being by far the most common, by far the most frequently occurring types of headache in this age group. Migraine seems to be more frequent in boys up to the age of 7. From the age of 7 to 11, the frequency is similar in boys and girls. After the age of 11, though, migraine is clearly predominant in girls. The prevalence changes with the onset of puberty, at which time migraine really becomes more prevalent in females. And early onset of menarche at or before age 12 is associated with increased migraine prevalence. So women are disproportionately affected by migraine throughout their life, particularly during the reproductive years. Most women with migraine find that their attacks are influenced by menstruation, hormonal contraception, pregnancy, and menopause. In fact, up to 70% of female migraineurs report menstrual association, and this is where the reproductive providers, reproductive community can really help these women. So which healthcare provider a woman selects may influence her course of treatment. Only 16% of patients with chronic migraine who consult a non-headache specialist receive a diagnosis of chronic migraine. So the issue is that if a patient is seeing their primary care doctor, the primary care doctor is trying to address so many things that they may not have time to get into the details of the headache unless they make a dedicated visit to that. In gynecology, many gynecologists haven't had the background training to treat headaches or diagnose headaches, but up to half of reproductive age women are seeing their GYN for their primary care needs. In contrast, neurologists don't feel comfortable with the use of hormones. So these women, especially with the menstrual migraine, really get stuck in the middle sometimes. This is why we're going to be doing a second webinar, really does a deeper dive into menstrual migraine, and we hope that you'll join us then. That should be a really helpful one for those of us who use combined hormonal contraceptives, especially given the updated CDC MEC guidelines that were just released a few weeks ago. So today we're going to do more of a general overview. We're going to talk about the menstrual migraines, treatment of pregnancy, lactation, and menopause. And Dr. Calhoun is going to do more of the heavy lifting for this webinar. So I'm going to actually turn it over to her so that she can talk to you about these.
Thanks, Dr. Patur. Yes, menstrual migraine has been kind of my favorite area since I switched over into this area full-time about 15, 20 years ago. But historically, when I first started doing talks on this about 25 years ago, there was one slide in the slide deck that said menstrual migraine, historically difficult to treat. I hope to change that. If you look here at this first slide, this is Stewart's work. It's been a while ago here, about 15 years, but he did a wonderful study looking at 82 women who had regular menstrual cycles and who also had menstrual migraine. And he simply had, who had migraine rather, and he had them simply plot their headache days in relationship to their bleeding. And if you look there at day 0, that's the day of onset of bleeding, there was a peak in migraine without aura and a peak in tension type headache, but no peak in migraine with aura. Now, this data is good as far as it goes, but around the same time, Katie published an article called the Spectrum Study, where he found that if you had migraine, all of your headaches were triptan responsive. If you did not have migraine, none of the headaches were triptan responsive. So I think I regraphed his data to answer a slightly different question. When do women with migraine have headaches in the menstrual cycle? And you see a much cleaner picture here. The only time that there's an increase in, if we put estradiol levels in the background, the only time there's an increase in migraine frequency is when estrogen levels are declining. And that is no coincidence. A little delay in the slide there, but several things happen when estrogen concentrations fall that are not good for migraine. There's a shutdown of serotonin synthesis. There's a very rapid degradation of whatever serotonin you have. And remember, all that our triptan medications are trying to do is increase 2 members of one serotonin family, serotonin 1B, serotonin 1D. But we're wiping out all serotonin. Beta endorphins are decreasing. And this new kind of villain in the headache world, CGRP, is increasing. So not good happening when estrogen concentrations fall. Now, the same thing happens with hormonal contraceptives. This Patricia Sulak's work, where she looked at patients on active pills and then patients on the placebo days here in the middle, and she had them simply plot their headaches. And there's an increase in headaches that occurs on the placebo pills, actually peaking on the 3rd day, Tuesday of the placebo week, given the traditional Sunday start. Now, if we look at what we're calling the architecture of oral contraceptives, comparing them to the natural menstrual cycle, the drop in estrogen that precipitates the menstrual migraine is roughly equivalent to 20 micrograms of ethinyl estradiol. So if we put birth control pills up next to this, you can see why back in the 1960s, that really was not a good idea to put somebody on one of those 100 microgram pills, and they had them even higher. Our only remaining high-dose pill accounts for less than 1% of doses in this country, but I used to draw the dotted line right there. Everything to the left of that line and above would make menstrual migraine worse. Everything to the right would not make it better. So it's sort of heads you lose and tails you don't win. But I drew a new line fairly recently when we had our first 10 microgram pill where the drop is only 10 micrograms. And we also have other options now. We have pills that go 3 months straight, and then a 30 microgram drop, some with a 20 microgram drop. We have one now with a 10 microgram drop, and we have those that don't drop at all. Now, to kind of make this simple, as far as what's this going to do to menstrual migraine, this is not a good idea, that's not a good idea, this one's not, this one's not, this one's not, that one's not, this one's not. Oops, there's a little bit of a delay. This 10 microgram one will prevent menstrual migraine in most people. The extended cycle with the 30 microgram drop is good until you hit that 13th week and then you pay for it. Same thing happens with the 20 microgram pill, but the one with the 10 microgram drop there will work for menstrual migraine, and continuous where you just don't drop at all will likewise work. Now, we're going to go back to what those are. But when Merced first came out, word on the street was that they were going to be adding estrogen back in the placebo week. And I thought, wonderful, this will do kind of what I've been doing for patients for the last 10 or 15 years, which is adding it back to prevent menstrual migraine. They'll be doing it for us. But they did it 2 days too late. You still have the 20 microgram drop, so you still get the migraine. So I simply published a short little study where I bridged over the gap, limited the drop to 10 micrograms, and we prevented menstrual migraine with that. And did it fairly inexpensively here as well. But now we've gone away since that first little open label study. I published this one a few years ago looking at 300 women who were prescribed hormonal preventives for menstrual migraine. And we had good calendar data and follow-ups on most of them, 229 evaluable subjects. Of those, we were able to prevent menstrual migraine in 168. 61 still had persistence of menstrual migraine when we counted up their scores. But of those who had persistence, 2/3 of them were taking the medicines that we prescribed. 1/3 either never filled the prescription or stopped it before the first month. But this is our comparator group, the intent to treat analysis. Now, when we looked at those, first of all, it was at a headache clinic, so like 92% had chronic migraine, 72% had medication overuse headache. But again, as I showed you, we were able to get rid of menstrual migraine in 73% of the intent to treat population. And when we resolved menstrual migraine, we were far more likely to also get them out of chronic migraine back to episodic, where the majority of their days are perfect, and get rid of medication overuse as well. Now, the same thing can be done with these extended cycle regimens. This is a Patricia Sulak study where she had women on the traditional 21/7 regimens of their birth control pills and simply had them list their headache complaints on each day. And you can see here with the 21/7 regimen, there's an increase in headaches in the placebo week. And then she transitioned them over to continuous contraception for 6 months. And you can easily see there eliminated that cyclic increase in headache. But there was an interesting little drawing in her article that I call the mystery of figure 2. In figure 2, she was showing the average daily headache score. This was for the patients who were on the 21/7 cycle. And then she showed their first 28 days on the extended cycle. And these regimens are only different from day 22 on. And you can see from day 22 on, it's a nice separation. It's statistically significant in their headache scores. But look back a few days there. There's also a statistically significant difference there beginning around ovulation time. And if you look at that, or just after ovulation, that's the post-ovulatory migraine. I think that's our first real example of it, statistically shown. Because on these extreme low-dose pills that we have these days, the 20s and 25s and 30s, a lot of women will, not a lot, but some women will ovulate on them. And if you ovulate, it's usually because you have 7 days off there for some follicle development. If one ovulates, then you have the whole hormonal change that occurs. I think this was good evidence that that was occurring. Continuous, though, after that first month would be good. Now, the regimens that I said that prevent the decline, and in most women will eliminate menstrual migraine. We have Librel and Amethyst. I think Librel is no longer sold by brand name, but Amethyst was the generic of it. Or you can do your own continuous, just whichever pill the patient does well with, eliminate the placebo days on a monophasic pill and go straight with it. We've also got low Seasonic, and be careful because regular Seasonic gives the 20 microgram drop, but low Seasonic only has a 10 microgram drop. And then there's Notasia, which I think is a little bit unnecessarily complex. It's the quadriphasic pill plus the placebo, so 5 different colors in the pill pack, but each drop in estradiol valerate is equivalent to less than 10 micrograms of EE decline. And finally, there's low estrin 110, and be careful with low estrin. There are 8 different ones. This is the only one that's 10 microgram. Now, let's move on here to treatment in pregnancy. I can remember back when folks were saying, well, the only thing that's category B in pregnancy is acetaminophen. Well, I mean, category A, of course, is pretty much just prenatal vitamins and thyroid hormone and replacement doses. Category B, yes, that's the only one that is B and stays B throughout pregnancy, regardless of the dose or how often you treat or the trimester. But we do have some better options now with enough years to look back at them. Let's look at triptans here first. Sumatriptan was first introduced about a quarter of a century ago. And a review of the data from the first decade after it was launched found no evidence of Sumatriptan teratogenicity when it was given in pregnancy. The Norwegian mother and child cohort, looking at about 70,000 pregnant women, about 2% of them used a triptan during pregnancy, and almost all of those were Sumatriptan, but they found no association between triptan use and congenital malformations. It was 0.9 for any and 1 for major congenital malformation, so no increased risk. We also have the U.S. and Canadian prospective registries, pregnancy registries, which detected no signal of teratogenicity. And I love this one, the Swedish experience. Over there, at the end of the first trimester, they capture all drug exposures, intentional or inadvertent, for the first trimester at a midwife visit at the end of the first trimester, and they're capturing over 95% of them. The risk of birth defects was 3.6% Sumatriptan and 3.6% in the entire Swedish population. And I'm sure, as you must know, that 3 to 5% is typically expected. So 3 to 6% was right where it should have been, given everything that we know. Now, we also have beyond that, the reason why we would want Sumatriptan among all of the triptans to be probably the safest one to use is that it's our only hydrophilic triptan. With the 8 different molecules out there, the slam on it for headache was always, well, it doesn't cross the blood-brain barrier. It doesn't need to, but the same factors that make it difficult to penetrate the blood-brain barrier also make it difficult to penetrate the placental membrane. Only about 15% of it gets across. And if you're using Sumatriptan in pregnancy, you certainly would want to use the nasal spray or this new nasal delivery system because you want a parenteral option. These patients typically have gastroparesis. Even if they're not actively nauseated at the time, there's significant gastroparesis, particularly in first trimester. So you also get the lowest doses with these. The nasal spray has 20 milligrams, the nasal delivery system 22, the lowest dose tablet is 25, and looking at maternal serum concentrations, they are lower with these two than with the 25 milligram tablet. Injections are 3, 4, and 6 milligram, most of them are 6, but even the 3 is much higher than the 100 milligram tablet. So you want the lowest dose you can get efficacy with. Now, category C, contrary to a lot of neurologists' opinion, C does not mean contraindicated. When you go A, B, C, D, and X, A is pretty much prenatal vitamins, like I said. C is basically saying that adequate studies have not been done in humans, and no one's expecting that they're going to be done anytime soon. But when you gave enough to half drown the fetal rat, you saw some trouble. Well, how much did they have to give the fetal rat? Well, if you look at this one, if you translate that, the milligrams per kilogram per day for a 70 kilogram adult, that would be about 70,000 milligrams of Sumatriptan a day. They did look at the highest safe dose out there. The highest no effect dose was 100 milligrams per kilogram per day, or taking no more than 70 100 milligram tablets a day. So again, the lowest dose we can get by with is the best, but category C doesn't mean contraindicated. No harm was seen in humans, but more information is needed. I think after 25 years we've got some good information now. Now let's look at treatment in lactation. Here we have the American Academy of Pediatrics guidelines to go by. They have this very nice table ratings for use in lactation. We can pretty much forget looking at category 7. That's basically broccoli and almonds, food and environmental agents. But if we look at drugs, tables 1 through 6, 1 would be cytotoxic agents, things like chemotherapy. That's just not a good time to be breastfeeding a baby. Then we've got drugs of abuse for which adverse effects have been reported. Here we're going to just say no. Table 3 would be radioactive compounds. Say the patient needs to have an MRI with contrast. We're going to pump and dump. But that leaves us with tables 4, 5, and 6, which is where most of the prescribed medications are. And these have been sort of abbreviated as concern, caution, and compatible. And just to fast forward through this, compatible is where all of our triptans are. So when we have a compatible drug, which one should we use? Well, one thing we want to look at there is the relative infant dose. Since virtually anything we take will be present to some extent in breast milk, we can calculate what the relative amount that the infant is getting in the breast milk is compared to the strength in the maternal serum. And we want an arbitrary cutoff of our safer drugs is to be using 10% or less. So of all of our triptans, probably the one that I would be least likely to write in pregnancy would be rizatriptan. Studies have not been done in human breast milk, but we know in rat breast milk the relative infant dose is like 500%. But 2 very low ones in humans, both sumatriptan and elatriptan, have very, very low relative infant doses. Ela is even the lowest here, 0.2 to 3.5 for Suma, so well below the 10% cutoff. And again, with these, the lowest effective dose is recommended. And finally, let's take a look here at menopause. Now, with menopause, if you go into either pregnancy or menopause with episodic migraine, they tend to get much better. But if you go into either of these with chronic migraine, you're in trouble. Things will get worse when you superimpose the sleep issues of pregnancy or the sleep issues of menopause. Because one thing that we all know in the headache world is the generator of chronic migraine is non-restorative sleep. Every one of our patients with chronic migraine wakes up tired. So with menopause, as a rule, yes, if you look by the decade, they tend to get better, but that's not disappearing there. But there's been a debate over whether surgical menopause is more of a problem than natural menopause. I am in the group that says I don't think there's a difference. I think hormonally the same thing has happened there. There's more testosterone gone with surgical menopause, but estrogen is going to be, they're gone with both of them. But I think what accounts for some of the differences seen in individual studies is where the population comes from. Working in a headache clinic now for a long time, I have seen a lot of these folks who have had elective hysterectomies just in the hope that it's going to help their migraines. It doesn't. And then also there's some comorbidity factors. Endometriosis is quite comorbid with chronic migraine. So you may be seeing some folks who've got both issues going on. But we also have some studies that really should never have gotten in peer-reviewed literature. I was actually not asked to review this Chinese study when it came out, but when I saw it, I immediately wrote a letter to the editor on it. In the Chinese study, they said that their surgically menopausal patients did far worse than the naturally menopausal patients. But if you look at the fine print, it wasn't that fine print. 81% of their, quote, surgically menopausal women still had their ovaries and very low FSH levels, and their average age was in their early 40s. So they still had menstrual migraine. Now, migraine does increase typically during the perimenopausal transition. That's a peak time for high frequency headache, which is equal to or greater than 10 days a month with headache. We often look at high frequency just before you get into chronic at 14 or more. But that's several reasons here. One of them is quite likely the shortening of the luteal phase, going from 14 days down to 12, 10, 9, have one, skip one, but you get the shortening where your menstrual migraines and ovulatory migraines are closer together. And then also there is a decrease in estrogen just as you're approaching menopause that can be symptomatic, where it's affecting sleep for 3 to 5 days at the onset of the period, and then it's back to normal again. But it's actually impairing the ability to achieve deep restorative sleep. If you look at some sleep studies that were done in menopause, although the total sleep time was comparable to controls, it takes longer to fall asleep. The sleep onset latency was longer. 20% of the perimenopausal women reported sleeping less than 6 hours, and brief arousals. These are things that patients aren't aware of. You have to be awake for several minutes before you remember being awake the next morning, but these were averaging every 8 minutes. And there were also 55 hot flashes a night, 40 of them with arousals. The stage 3, 4 of the deep slow wave sleep was reduced, and that's when you not only clear adenosine, but clear beta amyloid. So we have to get into enough of that to get rid of chronic migraine. And there's a 500% increased risk of sleep apnea, mostly central apneas, without hormone therapy, no increase with hormone therapy. Now, get a bit of a delay here on this slide. Caveats with hormone therapy in women who have a history of menstrual migraine. Just like with birth control pills, you want to avoid morning dosing. If a big trigger of migraine is a dropping estrogen concentration, and the peak time to have migraine is first thing in the morning, you don't want those two to coincide. So we're going to have them dosing it in the evening. Avoid short-acting estrogen formulations. I think when one of our estradiol doses first came to market, it really should have been a BID or TID dose from the beginning. Avoid days off at the end of a month. That's rarely done anymore. And caveats with non-oral therapy. With the 7-day patches, they can often wear off after 5.5 or 6 days, and if they're getting headaches, it's worse than if they're just getting hot flashes. And watch for cytochrome P450 interactions, particularly in this population. A big one to look for is topiramate and estrogen. Topiramate increases the rate of metabolism of an oral estrogen about 38%. So that would be a good place to use the transdermal. And triptans after menopause, age alone is not a contraindication, but if you look at the risk factors, that's the bottom one there too. So if you have 2 or more risk factors that need to be evaluated. So it's basically age plus either smoking, hypertension, LDL or HDL issues, or family history of premature heart disease. Now, let's take a moment here to look through a case, because in real life what you're going to find is fixing the menstrual migraine won't fix everything. There are other issues going on with most of these folks. But the case I want to show you here is a 48-year-old realtor with menstrual migraine, and she's now perimenopausal, and she has had a migraine without aura and menstrual migraine for a long time. She's now married with 3 grown children, and a little bit of delays here, sorry about that. And she has this chronic daily neck pain. In a headache clinic, 2 things I can almost guarantee you on a first patient. One is that they wake up tired every morning, and the second is they're either seeing the chiropractor, the massage therapist, or the acupuncturist for their neck. The neck pain will go away when the headache goes away, the chronic headaches. We see both of those resolving in over half the patients we see when we get them back to purely episodic. Now, here is her calendar. On the first visit, we have we put all of their calendars on a 28-day cycle, because I want to see things that recur in a cyclic pattern. We want to see them line up. So it's easier to see what's happening 2 weeks before that, too. But I draw a line back here and look at the last 28 days. And she has 7 severe days, 13 moderate, 8 mild. That gives her a headache index of 55. And if you look back here, 5 of her bad days are with her period. That's going to be repeatable year after year. If all we did is fix the menstrual migraine with something hormonally, she's going to be having mostly moderate and mild, with an occasional severe that's not lined up. So we have to fix everything to get her out of this. But we also, on the first each visit, will give them a symptom index questionnaire. And her symptom index questionnaire came out to 20, counting 1 for occasional, 2 for often. And then we're looking at her medications. And I'm noticing the Tylenol PM, 45 of them a month. I'm assuming that's not only for sleep, but also for some pain. But she's probably taking something else for pain, too. This is where we never let them say PRN. And by the way, my record for Excedrin is 652 a month. This doesn't come close to it. And she's also using hydrocodone, which is likely giving her some opioid-induced hyperalgesia on top of all of this. When we go through her symptoms, fatigue, she says she's worn out. The sleep issues, she says she's had trouble sleeping for 15 to 20 years. And the frequency of urination, she avoids every hour during the day, probably due to the 17 cups of liquid a day, which is intentional that she's taking, with urge urinary incontinence 3 to 5 times a week. Now, when we look at a strategy here, I liken it to a baseball diamond. Starting up at the plate, we have to have the accurate diagnosis. She has chronic migraine without aura and menstrual-related migraine. To get her to first base, we've got to, I like to say, shoot the elephant in the living room. She's got menstrual migraine. Those are the ones she's dreading every month. I have patients who with daily headaches, but that's all they want to talk about is the 4 days of work they miss every week for menstrual migraine. So we're going to eliminate her hormonal headaches by eliminating or minimizing the drops in estrogen. Second base, though, is to get rid of the background headaches. Get her to where she's no more aware of neck, face, or head than the 3rd toe on her left foot. Make it perfect above the shoulders. And we're going to do this by stopping the rebounding on medications and, more importantly, on non-restorative sleep. And we'll typically provide some bridge therapy for the first week of that. Third base, I don't even mention to a patient until after we've got perfect days, because they think I'm trying to sell them the Brooklyn Bridge. Third base is at that point to ensure that they never again have a headache that lasts more than 1 hour or recurs 2 days consecutively on the calendar. And that's the treat unbelievably early on the day after perfect with a fast onset Triptan. So if they get to perfect days, they've got to learn to treat immediately when they're first noticing a headache. Now, let's go back to her. So hormonally, we're going to get rid of this 30 microgram pill with the big drop and have no drops. We're going to put her on the amethyst at bedtime. We're going to get rid of the Excedrin and hydrocodone, and for that, we'll do some bridge therapy with that while we stop all of it. I think with her, I used Triptan twice daily for 2 days and half of one twice daily for the rest of the week while she stopped all of that. Afterwards, she's going to need a fast onset Triptan that she can take in place of the Tylenol PM. And then we're going to have to get a sleep study on her, a sleep history on her rather. Her sleep history, she gets in bed typically around 11 o'clock. But then she still has the television on a timer for 2 hours. She usually falls asleep before the timer goes off, but not always. Her alarm is set for 6:15, but she hits snooze until 6:30. On weekends, she'll sleep until 10, and she says she wakes up tired every morning. Now, during the night, she wakes up 5 to 6 times, twice to go to the bathroom, and if she gets out of bed, it may take her sometimes up to an hour to return to sleep. But it's really long. She'll watch television. It's an interesting thing I've noticed over the years. If people read to go to sleep, if they wake up and can't go back to sleep, they get a book out. If they watch TV to go to sleep, when they wake up, they turn the TV back on. So she's drowsy every day. She naps every day for about an hour at a time. Now, the sleep hygiene rules that we give all of our patients on that first visit, there are 5 of them based on a couple of studies we did back about 7 years ago. First is to schedule 8 hours time in bed, 9 if they're under 25. And that should be consistent weekdays to weekends, not vary more than half an hour one day to the next. No TV, music, reading, texting, anything in or on the bed. And the reason isn't TV or reading. The problem is they have rapid brainwave activity, rapid EEG activity with words in their head. We have to get rid of the words. We're going to replace the words with the visualization when we instruct them how to fall asleep. And then fourth is to move supper at least 4 hours before bedtime to reduce nocturia, and they'll also limit liquids to 6 ounces or less in the last 3 hours before bedtime. And finally, stop all naps, put more pressure on the sleep to be consolidated. Now, this is a little bit complex looking, but it came from one of the studies we published on this. If you look at the far left-hand column, of the 5 sleep habits we gave people, we looked at how many were still remaining after intervention. And if you go across, if they fix all of them, they do far better, and that's the top line, than if they don't fix any or only fix one of them. But the better way to look at this is in a picture graph. The light green lines were their baseline headache, the baseline headache index, which was ranging between 45 and 50. Follow up on the far left is if they fixed all 5 bad sleep habits. Far right is if they fixed none or only one of them. The study we published in 2007 showed that if they had 3 or more bad sleep habits remaining, no one reverted to episodic migraine. If they fixed all of them, only one person did not revert, and that's a lady who was sleeping with a cat she was allergic to. I didn't know anybody did that. She gave the cat away 2 weeks later. She reverted also. This is the patient's final visit, well, next to final visit, and this is the follow-up visit here. If we go back 28 days, headache index has gone from 55 to 9. But if we look at her follow-up here, she's still using Excedrin. And only 2 of those did she treat with her rizatriptan. Well, she says she often still uses Excedrin first. We have to get to stop that. That's the surest way to get into chronic migraine is what they call step therapy. Start with low and then move up, move up, move up. And by the time you go to the triptan, it's too late. But the one severe migraine, the first of that 3-day migraine, awakened her from sleep at 4 a.m. That is not uncommon. A study from several years ago showed that almost half of women, almost half of patients awakening with migraines, almost half of patients, their migraines began between 4 a.m. and 9 a.m. It's a peak time and shows why migraine is associated with non-restorative sleep. So we're going to fix all of that. Now, if they do still have headaches that awaken them from sleep, I typically want them to have an injection on the bedside table, because if we looked at speed here, our parenteral formulations, injections, and the nasal delivery systems are far faster than our triptans. We have the fast onset and the slow onset tablet. But an injection for the one that wakens them from sleep at 4 o'clock in the morning is the better way to go. The patient's final visit was here. She'd used 4 triptans in the month. Her headache index has gone from 55 down to 4. They were all little single-day twinges. The triptan relieves her headache completely in 30 to 45 minutes, and she says she's doing great. So this concludes where we are with this, and I think we are ready to turn this back over and take Q&A.
Great, thank you so much, Drs. Batur and Calhoun. This is Jessica again, and I will be reading questions from the question or chat box. So if folks want to use those right now to enter any questions they might have. Beth asks, are there any special considerations for pregnant or lactating women with ocular migraine?
By ocular migraine, I think you're referring to probably migraine with aura. That was an old term that was sometimes, are you talking about, if they're talking about any migraine with aura, no, there's no difference in treatment in pregnancy with triptans, just as there's none without pregnancy or lactation. They're treated the same.
All right, great. Lisa asks, any other options other than Sumatriptan for pregnancy?
Other than what are you saying for pregnancy? I didn't understand that.
Sorry. Are there options other than Sumatriptan?
Oh, Sumatriptan for pregnancy.
Sumatriptan. I'm so sorry.
Oh,
for pregnancy.
For triptan, that's the only one that I would want to go with. We don't have enough data on the others. And if you're looking for another, maybe a patient who didn't respond well to it, let me suggest that one of the reasons why people say, oh, I can't take this one because I had these side effects, often they're talking about side effects that would not have been seen if they had treated earlier. During a migraine, you know, that light's too bright, my voice is too loud, you can smell things from 4 blocks away. Side effects are increased as well. A little peristalsis will be nausea, kind of the wind moving will be a creepy crawly feeling. So we found that if people will treat earlier, their quote side effects are often gone. It's just that they've waited far too late, and the medicine doesn't work if they wait that late. Now, for other options in general, though, I mean, you could still do some. Folks will use Botox in pregnancy. You know, folks will use some nerve blocks, just depending on the comfort level of the people who are doing them. But I think for real treatment, we just try to fix what's wrong, not add drugs.
Okay, great. And everyone, if you have a follow-up question, feel free to ask that as well. Sophia asks, what about using methods of control that will eliminate the period like Depo or Mirena to eliminate menstrual migraine?
Well, Mirena will tell you right up front on their website they don't block ovulation. It doesn't work that way. The necessary part of a contraceptive is the progestin. That prevents pregnancy by 3 different methods. Preventing ovulation is only one of them. You don't have to prevent ovulation, and some of our good contraceptives don't. So we want one that will actually stop the ovulatory mechanism there. Depo is one that we just never use, because I've never seen any benefit from it with menstrual migraine.
Yeah, and the same goes true. Yeah, and the same goes true for the progestin-only pills. They less reliably affect ovulation. I mean, about half or less of ovulatory cycles are going to be suppressed on a progestin-only pill, So it's not going to be helpful for most patients with migraines.
Great, thanks. Betty asks, is there any data that indicates migraines are hereditary?
Strongly hereditary. What you don't inherit how bad the headache is or how often you get them. You inherit a threshold that's too low for setting off the trigeminal complex that Dr. Batur was referring to. It should be way up high, but as a migraineur, ours is low enough that things like estrogen falling, a weather front moving through, somebody wearing the wrong perfume, too much sleep, too little sleep, all these things can trigger it. Our next door neighbor with a normal threshold never gets a headache from the weather front moving through. They might get a sore knee, or they might be irritable if they don't have enough sleep, but they don't get a headache from it.
Great. Ashley asks, what about patients who cannot take hormonal contraceptives?
Well, there's a multitude of preventatives that can be utilized, and Cyclic is one of the more commonly used, but there's a whole slew of them, including the antihypertensives. Of course, you always want to consult the medical eligibility criteria because it's all about risks and benefits. So I have a lot of patients where it might be a category 3, so that's a relative contraindication for them to be on a control pill, but they have so many other reasons. I mean, they're on multiple other products. They're on antibiotics for their acne. They've got irregular periods, and when you talk to them about the risks and the benefits, then they're actually willing to they're willing to take the birth control pill because for them, for that individual person, the overall benefits outweigh the risks. So guidelines are just that. They're there to guide you, but they're not to dictate what you're going to do. So I think a lot of individualized care is helpful. So there's a lot of patients who are told, no, you shouldn't be on a birth control pill because their rheumatologist told them that they've got Raynaud's disease and they shouldn't be on a birth control pill. And they come to see me, they've got terrible migraines, they've got acne, they're having horrible bleeding, and I put them on a continuous birth control pill. They do wonderfully. Anne, did you have any other comments?
I would just absolutely ditto that. I see very few people who can't take birth control pills. I can think of one who, but that's in years and years. A lot have been told that they're not good candidates for them, but they've done beautifully on them and it's taken care of their headaches. A lot of it's quite, as Dr. Batur is saying, is quite relative.
And we're going to really get into this data, the nitty-gritty of the safety of the combined hormonal contraceptives, especially in women with migraine with aura in our next webinar. So anybody who has interest in this, I'd encourage you to join us for that because there's a lot of interesting data. We're going to go into the studies, what do they show, and I think it'd be helpful for all of us in the front lines who have to do this day to day.
That's a great point. Thanks. Kim asks, what are your feelings on amitriptyline as a daily medication for a 45-year-old woman with an IUD? Did I say that medication correctly?
Yeah, that's I do use amitriptyline in my practice. If people can get over the concern about the weight gain, but it really, for me, I find that it does help deepen sleep. And when you have issues with the sleep, if it's not something where they would also benefit from treatment of their menstrual migraines with a hormonal contraceptive, obviously, so they have an IUD, and so they've got the contraceptive. Yeah, I mean, amitriptyline does work well. It's a cheap, generic option. It's one of the options that we use for prevention.
Yeah, I like to say that chronic migraine is not due to congenital deficiency of Topamax, Neurontin, Depakote, Elavil, Inderal. It's due to a threshold we were born with we can't change, interacting with a lot of things we can change, like non-restorative sleep, medication overuse, whatever. I typically tailor my preventives to what are the triggers we're still left with. The hormonal ones we're going to fix hormonally, the sleep ones with sleep habits, the skipping meals ones with just don't do it. The one I'm almost always left with is stress. So I typically will use a water-soluble hydrophilic beta blocker as my first choice, a little atenolol. And I'll often use an SSRI as a second choice because it's increasing serotonin in the gap, just like a little having a little constant drip of a triptan going all the time. But I look at preventives mainly as fixing what's still left after we've fixed all the habits. I always say good diet, good exercise, good sleep. None of those involve pills.
And I think this question is getting at the patient already has a contraceptive method, and so you're looking for something else for their headache. I mean, one thing I do use in practice for women who are with a partner that has had a vasectomy or they've had a sterilization procedure themselves, so they don't need a contraceptive. Let's say they're perimenopausal. I actually take the higher dose, 1.5, 30 low estrogen, and I cut it in half. And for many women, that works beautifully. It has amenorrheic effects similar to the low estrogen 10 microgram dose, but it's not a brand name. Now, of course, if a woman is with a partner that has a vasectomy, you have to tell them this will not prevent pregnancy. So if she all of a sudden changes her partner, she can't rely on this as a form of method of contraception. But that ends up being a very low dose estrogen, or if you're worried about cardiovascular risks. So there's no reason why you can't use a very low dose of a product that helps, even if somebody has already an IUD or has had a sterilization procedure.
Mm-hmm.
Great, thanks. Marilyn has a quick clarification question regarding whether or not POCs are contraindicated in patients with aura, and whether progesterone-only pills worsen headaches and migraines.
The progesterone-only pills usually will not help migraine because it's not going to, in cases, will not block ovulation. We're going to have the whole other talk about combined hormonal contraceptives and migraine with aura. Technically, they are still on that list of category 4 with the CDC. I was actually invited to speak to that group. We thought we had swayed things to change it, and at the last minute after I left for a flight, apparently had another vote and they kept it. We've got several articles in process with that. Dr. Batur and I are doing an article coming up. I've got another one coming up for headache. I think there are some problems with this whole issue because they're combining studies done back in the 1970s when, yes, migraine with aura is known to have an increased risk. Birth control pills, combined hormonal contraceptives, since the 1970s have been found to have an increased risk of stroke when given to patients who have aura, or when given to migraineurs rather. I'm sorry, just by themselves. The original studies were just given to women, combined hormonal contraceptives. These were all high-dose pills. There were 50 to over 100 micrograms of ethinyl estradiol and 150 of mestranol, which is about, is over 100 as well of ethinyl estradiol. But they increase stroke risk about 4.4 times. My analogy to that is when you did studies on cats, there was a time in the Earth's history when cats were saber-toothed tigers. Most cats today are little domestic things we sling over our shoulders and pet, and the risk is very different. Birth control pills in the 20s and in 25 range, and certainly 15 and 10 ranges that we have now, don't have that increased risk. And we can't keep comparing tigers and house cats.
Thank you. Brian asks, for menstrual migraines in patients who have a contraindication to estrogen, what would you give instead of continuous OCTs?
I think we addressed this a little bit earlier, so there's multiple other migraine preventatives, but in the case of lupus, if you consult the medical eligibility criteria, not all, because I think that his question asks, example, history of DVT or lupus. So you want to make sure that the patient truly has a contraindication. So in the case of lupus, it would be, for example, if they have positive and known antiphospholipid antibodies, thrombocytopenia. If they don't have any of those contraindications, then combined hormonal contraceptives is actually a category 2, which means you can use it. So it's really important to make sure, because the CDC MEC criteria have just been updated. It's just in the last few weeks, and they have a wonderful app. The app used to be just available for the iPhone only, and now it's available for the Android-based format too. It's free. It has the STR as well. It's very comprehensive. So it's always good to make sure that when you say, okay, it's contraindicated, that you really look at the guidelines, because the guidelines tell you when in each disease is it truly contraindicated.
Great, thank you. Paige asks, what is your workup to diagnose migraine for women in their reproductive years?
Well, migraine is really diagnosed simply by history. So, in fact, in the headache clinic, we quite rarely are even getting imaging. Maybe that's what she's asking, but it's rare to do just basic imaging, because studies have shown this patient has a history compatible with migraine and a normal neurologic exam, the likelihood of finding something on an MRI or CT was less than 0.18%, and what they found in most cases there had nothing to do with a headache. It's just a non-specific little something that, oh, by the way, you've got this also, or you've got this. When we're getting one, it's usually for something different. And it's usually an MRV or an MRI, looking for something in a, if somebody has a long-standing history of headache that's gotten progressively worse over the years or decades, and a history compatible with migraine and a normal neuro exam, no other, quote, workup, for imaging is needed.
I completely agree. I mean, personally, I've had headaches since age 13. I've never had any imaging, and it's a personal pet peeve of mine when I see a patient that has gone from ER to ER, or same-day appointment to same-day appointment, and had multiple CAT scans. And I think it's just because of lack of time of providers. And I usually tell people, okay, for the headache, we're going to really need to make a dedicated appointment, because I remind patients that really you should, unless you have no choice, you really should limit the number of CTs of your brain to less than 10 throughout your lifetime. And I usually tell people, look, you're already up to 4 or 5. And when you start talking to these patients, well, they're going through their dietary habits, they're going through diet soda and caffeine like there's no tomorrow, all the red wine, they're not sleeping, and it's just a matter of talking to them for 15, 20 minutes and getting to the bottom of things. So this is where history and physical, I think, is critical.
I think we're both doing practice what you preach. I never got one on myself or on either of my 2 daughters who had chronic migraine when they were in college. They're both episodic now. My dad didn't have it, and his mother didn't have it either. We've all had migraine, but nobody had imaging, and we've all resolved it.
Great, thank you so much. Unfortunately, that is all the time we have for today. Thank you, everyone, for your participation and for asking such great questions. Here you can see we have a summary. So if you want to just take a moment to review that slide.
Oh, did you want me to? I'm sorry.
Sure.
Okay. Let's see if I can actually see it. Sorry, I was looking at the question. Menstrual migraine can be prevented by removing the trigger. Pregnancy and lactation. Best triptan choice is Sumatriptan due to its hydrophilicity and low RID. Menopause, hormone trigger is gone, but lifestyle ones remain. So keep in mind good sleep, good diet, good exercise, and avoid medication overuse headache.
Great, thank you so much. So thank you both again, Drs. Batur and Calhoun, for this excellent presentation. Before we end today's webinar, I'd like to share a few important reminders. Be sure to join us for the second webinar in this series on September 8th and registration is now available. As another reminder, you will receive an email from Caitlin Borthwitz in about an hour containing a link to the post-test survey. Your CME or Nursing CE certificate will be generated at the end of the survey. Be sure to print the certificate before closing the internet browser. If you have questions, please email us at education@arhp.org. Also, as an additional reminder, there are the 2 handouts. One of them is the migraine PowerPoint, so if you want to review the references or anything else in the presentation, definitely take advantage of that. Also, the updated medical eligibility criteria is listed right below that in the handout section. Thank you again for joining us today. We hope you will take part in other live and on-demand sessions hosted